Good morning, everyone. At the outset, I'd like to thank the organizers for giving me this opportunity. I would be presenting two abstracts. The first one is a systematic review and meta-analysis of neoadjuvant chemotherapy combined with endocrine therapy for hormone receptor positive breast cancer. It was presented in the Medicine Journal in November 2023. So, coming to the background, we know that based on various studies and meta analysis, mastectomy and breast conservation surgery have similar survival rates. But breast conservation surgery offers superior health related quality of life outcomes. So, whenever possible, we try to incorporate neoadjuvant therapies to improve the breast conservation rates. So, this study aimed to conduct a comparative analysis of the efficacy and safety of neoadjuvant chemotherapy combined with endocrine therapy against the backdrop of single neoadjuvant chemo or endocrine therapy, specifically in the context of hormone receptor positive breast cancer. So they did a literature search across the Chinese database and the English databases, and specific focus was on identifying randomized control trials that directly compared the combined approach of chemoendocrine versus single chemotherapy or endocrine therapy, and they used specific statistical packages to account for the heterogeneity to compare the analysis key analysis indicators, including the complete responses, objective response rate, disease control rate, pathological complete response rates, and the adverse events. So, in total, they identified around 135 records, of which, after removing the duplicates and excluding uh, uh, searches which did not match the criteria, around 11 articles were included in the meta-analysis, which involved around 1359 patients. It is a small number for a meta-analysis, but this was what they included. And around 50% of these patients received neoadjuvant chemo and endocrine therapy, and 47% received neoadjuvant chemo, and very small percentage, around 2%, received endocrine therapy in the neoadjuvant setup. When looking at the meta-analysis results, it revealed that neoadjuvant chemoendocrine therapy exhibited a statistically significant enhancement in the objective response rates and the pathological complete response rates, which was statistically significant when compared to the neoadjuvant chemotherapy. Nonetheless, when compared to neoadjuvant chemo or endocrine therapy, the NECT did not yield a significant impact on the complete responses or the disease control rate or the safety. In addition, the neoadjuvant chemoendocrine therapy demonstrated a significant improvement of objective response rates, especially among hormone receptor positive HER2 negative breast cancers. And but it was in this group of in this subgroup of patients, it was linked with heightened incidence of serious adverse events. So they concluded that neoadjuvant chemotherapy and endocrine therapy stands out as a significant contributor to enhancing the objective response rate and the pathological complete responses for hormone receptor positive breast cancer patients. And for breast cancer patients who are HER2 negative, it demonstrates a remarkable improvement in the ORR, but it also is associated with the emergence of adverse reactions. So, my comments. So, this is a meta-analysis which showed an improvement in objective response rates and PathCR in these group of patients, but the number of patients included is very small, and we know that in the especially in the hormone receptor positive group of patients, the achievement of pathological CR does not translate into an improvement in the overall survival. So is it really worth adding additional treatment in this neoadjuvant setup in these patients? And also in this present study, there was no comment or evaluation of the breast conservation rates in their meta-analysis. So my take-home message would be I would still continue to give neoadjuvant chemotherapy rather than addition of endocrine therapy, and would wait for more data on these outcomes when we plan to start neoadjuvant and add neoadjuvant endocrine therapy to these patients. So coming to the second abstract, this is the updated 5-year interim analysis of Monarch E study, the adjuvant abemaciclib plus endocrine therapy in hormone receptor positive, HER2 negative, high risk early breast cancer. presented in ESMO Congress October 2023. So we all know the background. Monarch E used 2 years of adjuvant abemaciclib combined with endocrine therapy in hormone receptor positive, HER2 negative, high risk early breast cancer, that is node positive. And this resulted in a significant improvement in the IDFS and the distant relapse-free survivals. And here they report the 5-year efficacy results from the pre-specified OS interim analysis, that is the interim analysis 3. So this is the study design. They included patients with high-risk node-positive disease. Cohort 1 included patients with more than 4 axillary lymph node positive or 1 to 3 lymph nodes positive if they had a grade 3 or tumor more than 5 centimeters. Cohort 2 included 1 to 3 nodes with Ki67 more than 20%. The stratification was by prior chemotherapy, menopausal status and region. The randomized to abemaciclib 150 mg BD for 2 years plus endocrine therapy for 5 to 10 years or endocrine therapy alone. The primary endpoint was IDFS, which was reached. Now they presented the OS data. So in the ITT population with a median follow-up of 54 months, the benefit of abemaciclib was sustained with a hazard ratio of 0.68, and for the IDFS, hazard ratio was 0.67, showing a significant improvement. So when we look at the year-on-year data, this persistence of abemaciclib benefit translated to continued separation of the Kaplan-Meier curves. It resulted in a 5-year absolute improvement in the IDFS of 7.6% when compared to 6% at 4 years and 4.8% at 3 years. And the distant recurrence-free survival was 6.7% at 5 years, whereas it was 5.3 at 4 and 4.1% at 3 years. So the Kaplan-Meier curves kept on separating, indicating a continued improvement in the IDFS and DRFS rates even after stopping abemaciclib. So the treatment benefit in cohort 1 was consistent with the intent to treat population and no new safety signals were observed. And there continued to be fewer deaths in the abemaciclib plus endocrine arm compared to the endocrine arm alone, though it was the significance was not yet met. So they concluded that at the pivotal 5-year mark of adjuvant EBC trials, abemaciclib plus endocrine therapy continued to reduce the risk of developing invasive and distant disease recurrence well beyond the completion of treatment, and the increasing absolute improvement at 5 years is consistent with the carryover effect, and it further supports the use of abemaciclib, especially in patients with high risk EBC. And the overall survival data are evolving in favor of abemaciclib arm, and the follow-up continues. And Monarch E is the only trial which has the of the two adjuvant CDK4/6 inhibitor trials. Monarch E has the longest follow-up data of more than 5 years, and more than 80% of the patients had a follow-up of 2 years, at least 2 years. So the 2-year adjuvant abemaciclib in high-risk EBC continues to show incremental improvement in IDFS and DFS even after stopping the treatment. And when we look at the OS data, it is still immature. But and to demonstrate a clear OS benefit in such studies, we may have to wait for longer years, like shown in the text and soft trials. So waiting for the final OS data would deprive many women of the benefit of adjuvant abemaciclib. And when we look at the patients who are living with metastatic disease, more number, almost twice the number of patients who received endocrine therapy alone are developed and are living with metastatic disease when compared to receiving abemaciclib. So my take-home message would be patients who fit in the high-risk criteria would benefit with the addition of abemaciclib as adjuvant therapy for 2 years. Thank you.